Hi friends, happy Ugadi, happy Gudi Padwa, happy Chaitra Navratri and happy New Year for Hindu New Year. Wish you all a very happy Ugadi and Gudi Padwa. Friends, today I am going to discuss with you on this auspicious occasion a very important topic, that is diabetes mellitus. And because I am an anesthesiologist, I would love to talk something related with anesthesia and diabetes mellitus. Well, the stress of surgery, anesthesia and illness increases secretion of counter-regulatory hormones, which are cortisol, glucagon, growth hormone, catecholamines, which in turn causes decreased insulin secretion, increased insulin resistance, decreased peripheral utilization of glucose, increased lipolysis and proteolysis. As a consequence, gluconeogenesis and glycogenolysis increase, which subsequently results in worsening hyperglycemia and is termed as stress hyperglycemia. Uncontrolled hyperglycemia instigate osmotic diuresis, causing fluid and electrolyte imbalance, friends. Ketogenesis and increased generation of pro-inflammatory cytokines with resultant mitochondrial injury, endothelial dysfunction, immune deregulation. Hence achieving blood glucose control during operation and perioperative period is very, very essential, friends. And one more thing. It's so important to know the type of diabetes. Friends, the risk of complications such as ketoacidosis and perioperative management of blood sugar may differ in type 1 and type 2 diabetes. I'm sure you know type 1 diabetes is beta cell destruction, usually leading to absolute insulin deficiency, causing immune-mediated and idiopathic changes. Normally it is immune-mediated or because of idiopathic changes, the type 1 diabetes. And in type 2 diabetes, which could be predominantly insulin resistance with relative insulin deficiency, to a predominantly secretory defect with insulin resistance. Friends, the complications of diabetes must be known, which depend on blood sugar control and duration of diabetes. Good blood sugar control is known to reduce risk of microvascular complications, though the evidence is not perfect. Now, what are the complications of diabetes? You know, the mechanism of injury is osmotic stress, which I had just mentioned, from sorbitol accumulation, formation of advanced glycosylated end products, free radical production, and reactive oxygen species formation. So what happens in diabetic nephropathy? Glomerular hyperfiltration, increase in glomerular hydrostatic pressure, causing glomerular damage, and microalbuminuria. And what happens in diabetic neuropathy, which is the complication of diabetes? Chronic sensory motor distal symmetrical polyneuropathy. Most common symptoms are burning, tingling, and numbness. And DAN, what is DAN? DAN, diabetic autonomic neuropathy, is the biggest complication of diabetes. Autonomic dysfunction is detectable in up to 40% in type 1 and 17% in type 2 diabetic patients. Mechanisms suggested include local ischemia, tissue accumulation of sorbitol, altered function of neuronal sodium and potassium ATPase pump activity. Diabetic retinopathy, that's also one of the important complications of diabetes. What you see is dot hemorrhages, hard exudate, microaneurysm, and retinal edema. So don't forget, when you are assessing this diabetic patient, do the prayer sign. Very simple test. The ability to oppose the palms and fingers as in prayer. Diabetic patients with stiff joints have a positive test as they are unable to do this prayer sign. So what are the airway problems in diabetes? The stiff joint or limited joint mobility is also known as diabetic arthropathy. It manifests with joint rigidity, joints supporting the airway such as temporomandibular, atlanto-occipital, and cervical spine joints are most commonly stiff and are then involved. Neck extension and laryngoscopy would be invariably difficult. So how will you assess the autonomic neuropathy? That's very important. Important clinical signs are resting tachycardia, lack of sweating, early satiety, sexual dysfunction with the patient complaint, and the lack of heart rate variability. And what is this heart rate variability? I'm sure many of you might be knowing, but let me repeat. Now, what is this heart rate variability? Respiratory sinus arrhythmia is normal phenomena due to vagal input to sinus node during expiration, causing cardio deceleration. That means the heart rate decreases during expiration due to vagal input and causes sinus arrhythmia in the form of bradycardia. This is normal phenomena. But in autonomic neuropathy, it decreases heart rate variability. The difference in between maximum and minimum heart rate during respiratory cycle is missing. So that is a diagnostic sign of diabetes. So what do you want to know and what you should know about the anti-diabetic treatment when you are dealing with patients of diabetes mellitus? Preoperative control of blood sugar is very important, especially HbA1c control. The preoperative control of blood sugar is best assessed with HbA1c. So that is very important, and it should be preferably less than 8.5 for elective surgery. Sulfonylureas, which are usually used for treating diabetes, enhance the secretion of insulin in response to glucose and increase sensitivity to its peripheral action. What are these first generation agents? Tolbutamide, tolazonide, chloropropamide. They have long duration of action. Second generation, for example, glipizide, gliburide, glimepiride, glibenclamide has longer duration of action and more likely to cause hypoglycemia, especially in the presence of renal insufficiency. Now, very often we use bigonides. Metformin is the best example. Metformin is the first line treatment in type 2 diabetes mellitus. Its mechanism of action is sensitizing the liver to insulin and reducing liver glucose output. Friends, it also involves insulin sensitivity in peripheral tissues and decreases serum free fatty acid concentration. Metformin is well tolerated and is less likely to cause hypoglycemia than sulfonylureas or insulin. But the biggest problem of metformin or the bigonides is the production of lactic acidosis. Lactic acidosis associated with metformin is rare but has high mortality rate. I'm sure you are aware of. Therefore, metformin should be prescribed with caution in patients with moderate or severe renal or liver disease. So that's very important to know when you're using metformin. So during anesthesia, how do you normally manage? A careful induction with etomidate is preferable, or high dose fentanyl. That means high dose means 4 to 5 microgram per kg of fentanyl. You can call it fentanyl with midazolam, and also it could be given with thiopentone. and should be performed in patients with cardiovascular complication. Exaggerated hypotension due to autonomic neuropathy is normally common in such patients who have cardiovascular complication. Succinyl choline should be avoided. Why? In patients with extensive peripheral neuropathy due to risk of increased potassium release. Preferable muscle relaxants are atracurium and mivacurium. They are preferred in presence of renal dysfunction. Rocuronium may be used in rapid sequence induction, RSI, rapid sequence induction. Anesthesia is maintained with isoflurane or sevoflurane in air, oxygen, or oxygen nitrous oxide mixture. Friends, you should know about few points about hyperglycemic emergencies. What are they? Diabetic ketoacidosis and hyperosmolar hyperglycemic state. Diabetic ketoacidosis has classical triad of ketonemia, hyperglycemia, and metabolic acidosis. It is seen in type 1 diabetics and patients with type 2 diabetes. Also, during the catabolic stress of acute illness such as trauma, surgery, or infection. Diabetic ketoacidosis is sometimes the presenting feature of type 1 diabetes. Diabetic ketoacidosis is sometimes seen due to discontinuation of anti-diabetic treatment or with drugs that affect carbohydrate metabolism, such as the drugs that affect carbohydrate metabolism are corticosteroids, thiazides, sympathomimetic agents, and some antipsychotic agents. Hyperosmolar hyperglycemic coma. This is also one of the hyperglycemic emergencies with diabetes mellitus. Hyperosmolar hyperglycemic state is seen in type 2 diabetics, more commonly in elderly people with coexisting diseases. Hyperosmolar hyperglycemic state may be caused by plasma insulin concentration that are inadequate for glucose utilization but are adequate present lipolysis and ketogenesis. Friends, I'm sure this was quite informative, educative, and a bit of entertainment too, because the way I have presented this complicated case of diabetes was definitely to entertain you and educate you. Once again, a happy Ugadi, happy Gudi Padwa, happy Chaitra Navaratri, happy Hindu New Year. This is Colonel Pradeep Pindyala, Professor of Anesthesiology at Ashram Medical College, Eluru city of Andhra Pradesh, India. Until next time, take care. Bye-bye.